I'm going to ask maybe Ian to talk about one of the things that actually is the most common thing in my practice, which is people coming in on treatment and either having a complication or even not having a complication. And I think about kind of switching. So I wonder if you have an approach towards people that come in on treatment and how you kind of think about optimizing their.
Well, I agree with you. This is the most common treatment decision that I make in my practice these days. I've been taking care of people with HIV for a long time. And I tend not to see a lot of newly diagnosed individuals. Those go to the younger people in our practice. I look at the antiretroviral regimen of every patient with the question of, can I improve upon this combination? I want to make things simple, few pills. I want to make it convenient, as flexible as possible. I want my patients to be able to take their drugs during the day, not just at night, with food or on an empty stomach. And even in people who have no symptoms, if they're on a regimen that is not a preferred regimen, I want to get my patients onto a preferred regimen. I want to get them onto an integrase inhibitor-based regimen. I want to try to cut down on the number of pills. And there are a lot of tools that we have available to us to do that. We have resistance testing that could look at archive mutations in HIV DNA for our patients who have maybe failed in the past or come to us from some other practice with an unclear history. So we could see whether or not we can detect any baseline resistance prior to switching therapy if resistance tests are not available to us. We've got agents of next generation NNRTIs. We've got next generation integrase inhibitors. So we have options for people who have failed on some of the earlier agents within therapeutic classes. We've got effective 2-drug combinations now. We've got dolutegravir lamivudine, dolutegravir rilpivirine for people who have not failed on an integrase inhibitor-based regimen before, as well as the standard 3-drug combinations that have all been proven to be effective in the context of switching somebody with virologic suppression.
So Colleen, the kind of 2-drug combinations, is that something that, just from my point of view, I feel a little safer with 2-drug combinations and people that are kind of securely suppressed?
Absolutely, and I will say that's where I'm doing most of my 2-drug combinations. I think in general, I still see very advanced disease. So initiating 2 drugs still makes me a little bit nervous, similar to the adolescent questions, although I'm becoming a convert. I'm getting there. But I think absolutely once someone is suppressed and they do not have ongoing replication, the amount of drug pressure that they need, I feel very confident, is less than their initial start. And so I will often drop them back to 2 drugs once I feel like, we've gotten to a stable place. We can reduce the pill burden sometimes. We can take off things that may have long-term side effects or maybe interacting with other medications that they're on. And so that is the setting where I end up using more 2-drug regimens.
Yeah.
I think, because we previously only had single tablets that had 3 drugs or so. There are people where that 3rd drug probably wasn't really doing much, but we had to use it, right?
Sure, right. Yeah,
so now, with you, Ian, going back and saying, well, this was actually never really working, and so they actually could get away with just a dolutegravir rilpivirine. I've done that.
Sure.
So I take care of a lot of perinatal acquired individuals in their 30s, and their nukes are not they're not
they
active.
have nukes and protease resistance,
Exactly.
And you can give them a regimen that has neither.
Right. And all of a
then
sudden,
they're like,
34 years old on a 1-pill regimen.
Right.
So that's really been
my mantra's been kind of the simplest, safest regimen that fits in a person's life, and just forcing myself with every patient that shows up to kind of, do that little calculation. Is this really, the simplest and safest thing they could be on? I mean, virologic failure is a toxicity. It's a adverse event. So we want to be careful. And I think Ian, mentioned that you can do some things to look for previously present resistance, and you certainly should find all the old genotypes and stuff like that, do things that make kind of clinical sense. But I do think we can get people into some pretty safe places. And some people, like you said, on very complicated regimens, and then you think, oh, wait.
Right. Why are we doing that?
Yeah,
Right.
right. Yeah. I recently had a 80-some-year-old woman who was on 3 drugs. She'd never been on 2-drug therapy or just nucleoside therapy. She'd always been on 3 drugs. She's been suppressed since like 2012 or 2011. And she had osteoporosis. And, whether it's TAF or TDF, does she really need that? She's 80 years old, So just that kind of thinking. And some of us that are older, we grew up on 3 drug.
Right. The mantra.
Right. It may not exactly be what we have to do.